Ouais, d'accord, ok. Mais
Oui, oui, c'est mieux.
Ok, ça marche. Ah oui, d'accord. Okay. Et là, je suis sur Chrome. Même sur Chrome, ça marche pas. Bah, sur Chrome.
Shall I try mine?
Yes, please, sorry.
C'est le Firefox. Non. PowerPoint. Paf.
Marcelo, do you think that it will be a possibility in the near future to change for Zoom, because possibly
I can't share my screen. I can't share my screen, and it's going to be a mess, this meeting. I can send to everybody a link to a Zoom meeting if you want, because otherwise I don't think we can go ahead with the meeting. I can't share my screen.
If we do this, we'll have trouble linking to the YouTube channel, right?
Yeah, but I mean, we can have a bigger problem with the YouTube channel.
For example, Marcel is able to share the screen.
Yes, I was just trying. I can share my screen perfectly.
Sometimes what happened to me once was that I got out and came in again, and it works.
Yes.
I can also Beatriz that she's already here. She can try to share the screen. Marc Antoine also got it.
Yeah, so Marc Antoine is good. Okay. It's good, Marc Antoine.
Yes.
Okay, good. Okay, good. We see your screen.
Yes.
It's okay, Marc-Antoine. Please, your microphone should be open.
Okay, let's go. Thank you very much for inviting me, for presenting and discussing such a case. So this is, you can hear me, is it okay?
Yes.
Yes.
Yes. Okay, so this is a story of a 59-year-old female. The story began in August 2021. So except obesity, she has no special medical history. So the story started in another center where she was managed for a true common bile duct stone with ERCP, and it was she underwent a sphincterotomy, which was uneventful. And after 2 months later, she underwent a laparoscopic cholecystectomy. 4 months later, so we are 4 months from the ERCP, she was hospitalized for a fever with a bacteremia, which seems to be a cholangitis. And you can see blood count and coagulation tests were normal, but you can see here a cholestasis with elevation of gamma GGT and phosphatase alkaline. Serum bilirubin was normal, and CEA and CA99 were also normal. So I show you here the CT. You can see here like a bile duct dilatation of the biliary tree here, and we can see something here in at the biliary confluence here. You can see there is something inside. So we decide to continue. So you have here two pictures summarizing the city. Something inside. We have the feeling that there is a lesion or something inside the biliary confluence. So we did an MRI that you can see here, and which confirm what we have seen, something inside the right bile duct biliary confluence. So here you have some pictures summarizing the case. Here, the 3D reconstruction of the MRI. Okay. So in summary, this is a 59 years old female, cholangitis, 4 months after ERCP for common bile duct, followed by laparoscopic cholecystectomy. Cholestasis without jaundice, and imaging lesion, we don't know yet what it is, inside the right bile duct reaching the confluence. So what are your hypotheses?
So I moderate this case, and I ask in the audience whether somebody has an idea.
Have you done a spyglass?
Hugo?
Yes. I would say if she had an ERCP before the cholecystectomy, one of the hypotheses I would put would be probably a bleeding inside the bile duct and eventually a blood clot. It is very strange that a lesion, a solid lesion, appears so little time before.
So I'm to address your question, I must say that the ERCP was done in another center in the Antilles, and we have no access to imaging done during this ERCP. So we have only a report of the ERCP, and they say that they just removed a common bile duct stone, and they didn't notice or they didn't report anything else.
May I say something?
Yes.
You suggest, Hugo, you suggest it was a clot. This is what you suggest?
Yes, eventually, but it's very some months apart. It's very long time.
Common, a clot stay like this, block at the confluence. Usually, when there is an image like this one in the bile duct, usually there are two options: or it is a stone, or it is a tumor. Is, I must say, the most common obstacle in the confluence. So we have to think about these two causes, rare cause like a compression by a lymph node, but this is rare. So the most common are these two.
I think there is a third possibility, but I will see Gina and Tomoaki are raising their hands.
Just one question. During the laparoscopic cholecystectomy, have you done an intracolangiogram?
So laparoscopic cholecystectomy has been done in the center where has been done the ERCP, and no cholangiography has been done at that time during the cholecystectomy.
Okay. It was not in our center.
Yeah. My question was, have you done a spyglass?
Yeah, this is the next thing. It's what we should do,
Yes.
because there may be many hypotheses and one thing to do. The one thing to do for me is a spyglass. I would add a third hypothesis, which is injection at the cholangiography of a toxic fluid into the cholangiogram because of a nursing mistake, and that can happen with the antibuée, with the liquids of the anti-fogging liquid.
Just one thing, Pietro, may I? Is there any story of parasite infection also before?
No, we are no specific previous medical history except obesity and hypertension. That's all.
I think we should. And on the CT scan, the artery was fine, wasn't it?
Yes, exactly. Artery was fine.
Good. Then I think we all. Surendra is raising his hand.
Yeah. It could be a sludge ball because there is a plastic stand there. It's a foreign body. It gives rise to precipitation, and there could be a sludge ball rather than the main stone. So I agree with the Hugo, the possibility of clot, a sludge ball, and of course the rarity that it could be a tumor. That will be a rarity. Best thing will be to do the ERCP, remove that stent, and do the cholangiogram. You will get the idea. If it's sludge ball, they will flush it out. With the balloon, they can sweep it out. And if
Surendra, I didn't understand what you think it is. I didn't understand the word.
I will put it that a sludge ball is the most likely thing.
A what ball?
Sludge ball. Sludge. Biliary
Sludge.
Yeah.
Right. Sludge ball. Right. So in fact, it's under a stone. I mean, on the category of what Mr. Bismuth said, a stone, a biliary sludge. Right.
Yes.
But there is one thing to do is spyglass or ERCP and try to get this thing out.
And Pietro, even if you are putting several hypotheses, even material from the previous ERCP that we don't know how it went could also be an hypothesis.
That's very remote. I mean, I don't see ERCP going in. It can be a sludge of epithelium. My hypothesis is a sludge of epithelium from a toxic, something that was injected in it.
Okay, we can proceed.
May I say a remark, Pietro? Yeah, it is not in this case, but sometimes we may observe if there is, after cholecystectomy, an injury of the bile duct, a partial injury. And then there is a formation of a stone, and the stone above the injury may, at that time, render symptomatic the injury. But in this case, I cannot think about that, because it is too short. 4 months after, it is impossible to have the formation of the stone. I mean, I say that, but I exclude that.
It may be something that was there before and was missed at the RCP, which I think is the most probable thing. Yes? So what did you do?
So we continue our exploration, and we ask, as this has been said, for a cholangioskopy, for a spyglass. And I will show you the movie of the spyglass here. So this is the spyglass, and you can see this is the confluence. This is biliary confluence, and you see on the right side, on the right bile duct, something inside. So you can see the picture here. This is something inside. Look at that, very beautiful. And you can see that the left bile duct seems to be okay. Seems to be okay. Okay, so this is the movie of the cholangioskopy. Somebody has any diagnosis?
Very curious.
Not a stone.
Yeah.
It seems tissue.
So
Biopsy.
So some biopsy has been done. I will show you. I will try to show you maybe the best picture. So yeah. At that time, does anybody has any?
Did she have exploration of the bile duct during the cholecystectomy or not?
No exploration of the bile duct during the cholecystectomy.
Can this be a mucinous tumor of the right bile duct that was missed in ERCP?
Yeah. Absolutely. And so what says The gastroenterologist that performed the cholangioscopy told us just at the end of the right bile duct, an exophytic lesion, swift texture, without ulceration or stenosis. And the biopsy showed biliary papillomatosis, gastric septate, no tumor cell, and low-grade dysplasia. So, in summary, we have 59 years old female, cholangitis, intrabiliary papillary and mucinous neoplasia of the right bile duct, low-grade dysplasia. So what's your proposition? Watch and wait because there is low-grade dysplasia, or resection? Which kind of resection, if resection?
John?
So thanks, Pietro. I imagine papillomatosis is the older term for what we now refer to as IPMB. Yes. All these mucinous lesions are subsumed under the pathology of IPMB. And we are learning that this is a much higher malignant risk than we thought before. So we have to anticipate the malignant transformation, even though you have a low-grade dysplasia. From what I understand, it's at least about a 30% malignancy transformation risk, and that's going to inform the decision.
Yeah.
Okay.
I would say I agree with John, and I would say that there's a significant risk of malignancy, and the low-grade dysplasia is just a sample of the tumor. So I would propose this patient for resection with another thing, that these IPMBs are frequently multifocal. So we'll have to be very, very sure that the left liver is totally free, because I assume this is for a right-sided resection, probably a right hepatectomy. That the left liver and the distal bile duct are totally free of tumor.
Okay. There's usually, you can look for the KRAS mutation, and that's the one which is associated with malignancy. As far as I remember, and this is the cases in bulbous, you have two cases, which we have at that time called intrapapillary biliary papillomatosis. Both of them had recurred after a simple liver resection. And at that time, the prognosis was to go for probably transplantation, keeping in mind that it can invade the extrahepatic biliary tree. So that's the situation. So I will propose to go for it because she's young, but you have to think about the whole liver and probably go for transplantation. But I would do some other tests, mostly to look for the KRAS mutation to see whether it is positive or negative.
Okay. So we didn't do KRAS mutation, the search for KRAS mutation biliary cancer risk, even if the negative biopsy, even if biopsies are negative. We all know that negative biopsies have no value, and there is a risk of cancer transformation in the meter. So which resection do you propose?
Hugo, you were saying that you should do a right hepatectomy, if I have understood well.
Yes, when I saw at least the images, it looked like it was located essentially in the right branches. But when I look at this, at least it goes up to the confluence. So I think at least a right with the biliary reconstruction to the left.
Mm-hmm.
And I think we have no volume also.
Yes, we have a low volume. Indeed, as you can see, the left lobe is very small, and I will give you after the volumetry, but indeed, she has a native small left lobe. Okay, so indeed, we propose a right hepatectomy, not extended to the 4 or to the segment 1, because of you can see that the left lobe, the volumetry of the left lobe was only 0.3% of the body weight, and we associated the case with bile duct resection. And we decide to make the removal of all the common bile duct and make an hepatico-jejunostomy. We decide to treat this patient as if she has a perihilar cholangiocarcinoma. I will show you here the intraoperative ultrasound. You can see here, this is the right bile duct with the tumor inside that we can see in the portal vein below. Okay, this is very unusual to see such a picture. This is the intraoperative when we cut the left bile duct here. Okay, and the final picture. Okay. So we make a right hepatectomy with common bile duct resection and hepatico-jejunostomy on the left bile duct. We did during the surgery an intraoperative cholangioscopy, as it has been said, to know if there are other lesions on the left side. So it was possible to do it intraoperatively, and as you can see, no, we did not find any specific lesion on the left side. So the definitive histology was IPNB, biliary phenotype, finally, of the right bile duct, low-grade dysplasia. The 6 lymph nodes were all negative, and the bile duct, low and left bile duct stump. We found some low-grade bilin at that point. So just one word about intraductal papillary biliary neoplasia. This is a rare benign tumor, but it should be considered as a precancerous lesion with a risk of transformation of about 40%. Location and extension are extremely variable. It can be common intrahepatic and extrahepatic extension in the majority of cases. We know that factor of poor prognosis after resection are mainly L1 resection, invasive carcinoma, and a positive lymph node. So take-home messages for this case. Usually, we should think about IPNB when we have a mass, intraductal mass, and without jaundice. Often, especially after ERCP, patient can develop cholangitis. There is a risk of transformation. Exploration with spyglass for mapping and biopsy is extremely important. And our philosophy and the policy is to treat this patient with curative intent, so hepatectomy with biliary resection as it is a cancer, as if it is a cancer, and of course to continue to follow up, to follow this patient for long term with MRI. This was what we decided, MRI every 6 months at the beginning. Thank you very much.
Thank you very much. Very interesting. And I think a number of hilar cholangiocarcinomas of the papillary form were in fact this kind of tumor.
Can I ask something?
Yeah.
It is a nice case, well treated. I have a question. What do we hope to see by the follow-up, the 6-month RMI follow-up? What are you expecting to see?
No, we consider that on the biliary tree, there is some bilin. We found, the pathologist found some bilin, which can be maybe a pre-malignant state, and maybe this patient may develop another tumor in the future, but of course we don't know. But we consider this patient at higher risk than the general population to develop another tumor on the left side. So the idea is to follow, and if something appears on the MRI, on the biliary tree on the left side, then of course we can discuss eventually a transplantation. Of course, it is the rhythm of follow-up, if it's once a year or once every 6 months. Very frankly, this is totally, it's a bit arbitrary. The patient is a bit anxious, so we propose to stay on a rhythm of 6 months, but maybe it can be discussed to make only once a year. I don't know the opinion of the audience.
You did not discuss the indication of doing the transplantation now. Well, you know, what you said is you are waiting for a cancer. This is what you say. Due to the high risk of cancerous degeneration in the remnant bile duct. But you are waiting, that means indeed, by the follow-up, you are waiting that a cancer may develop. You said that the risk of developing cancer is high. She's, I think, less than 17, less than 60.
Yes, 59.
My question, do you think you may discuss the liver transplantation now?
What we have learned with this case is that you can see that the tumor was big and it was only low-grade dysplasia. So if she relapses, our hypothesis is that she will relapse under the form of another papillary tumor with probably low-grade and low rhythm of evolution. So at that time, I think we don't take too much risk for her to follow up for the moment. And if something appears, then we will go for transplantation, knowing that probably if something appears, very likely it will be low grade. But I acknowledge that this is a bit a bet. I mean, we never know what's going to happen in the future. So I think the discussion is still open. Knowing that transplantation, there is, of course, always immunosuppressive therapies. There is always a 10% risk of mortality at 1 year. So liver transplantation is not a no risk procedure also.
Pietro, may I ask you, Pietro, what is your idea on this point?
I activate my microphone. I would have done exactly the same thing. I mean, her bile duct on the left is clear, and by a good cholangio MRI, you can see small polyps appearing, and then transplant the patient at that point. But to transplant her now, it's even too early, because I don't think there is a reason for that. Of course, she may become 75, and then what do you do? But at the moment, I would not transplant her, I would wait for recurrence.
May I do a comment?
Yes, but then there are 3 people speaking, and Gina, if you don't mind, I will let you skip by because there is Tomoaki and Hugo.
No, the first point is regarding transplantation. This patient may be cured, but what we have done, we don't know. But she may be cured by the right hepatectomy we have done. And by this way, to do a sort of preemptive liver transplantation could appear excessive. I'm not so sure that the patient will accept, first. And second, in view of the organ shortage, it seems difficult to defend the upfront hope of liver transplantation. But I agree with you, Monsieur Bismuth, that indeed there is a risk of first developing skip lesion on the left side of the bile duct, and by this way also a possibility of further malignancy in the hepatic duct. But by this way, today, it seems too early to consider liver transplantation. This is the first point. The second point, Marc-Antoine, you mentioned about the volumetry. If I remember well, we did or we didn't done a right portal embolization.
Yes,
Because this
I
is
didn't
also a
mention
matter of
that.
discussion.
Yes, we did a portal vein embolization indeed before. Absolutely, because she has a small left liver and a very small left lobe constitutively. So the patient was 90 kilograms. So in order to avoid any risk of liver failure, portal vein embolization was performed before surgery.
So this was
And
another
also drainage of the left liver.
So this was another message. We choose the safety as much as possible in this patient with apparently a benign lesion, not to take a high risk by doing a right hepatectomy with a remnant liver too small.
Okay, Hugo?
Yes, I would say about liver transplantation, I would probably not propose it at this point because I think that we have two risks, the risk of intrahepatic recurrence and the risk of distal recurrence. And we had a bill in the distal bile duct, as I recall. So it wouldn't remove the risk of the distal bile ducts also. And I am not sure about this, but I think there is even a relation with pancreatic IPM ends. So I'm not sure if this is a whole disease of the biliopancreatic ducts that really has to be followed and nothing else.
Yeah. Thank you, Hugo. Tomoaki?
Well, I don't have much to add, so I'll be very brief, but I thought that, recurrent risk was inflated because it is more likely the data from if untreated. So is it a clear post-resection recurrence rate was really reported?
Yeah, yes. In the publication, early publication during late 19th, you have publication about biliary papillomatosis. And in these cases, specific cases, they all recurred after liver resection. And if I may add a very, very short comment, sorry, Pietro, about the follow-up. One thing is that the best way to follow them up, it's regular liver function test. Even if they are normal, the slightest increasing of the gamma GT is an early type of intra-biliary recurrence, very early stage of cholestasis coming up. This is one way to follow them up better than only imaging.
Okay, thank you.
Right.
Thank you very much for this.
Now, Hugo, how many cases do we have just to time?
So we have 4 more.
4 more, right. So the moderator is René, isn't it?
Yes, if you want.
The official?
Okay,
Yes,
so we have as many speakers as a chairman, if I understand.
Thank you very much.
Okay, it's okay, thank you. Okay, so the next case is by your team, Hugo.
Okay, so I ask Beatrice, she's here, to share the screen. Beatrice?
Yes, hello, good morning.
I hope it works. Okay.
Good.
Okay, so can you see?
Yes.
Okay, so I'll begin. Firstly, thank you for the opportunity to present here. Our case was recently referenced to our center and begins a while back in 2004. So at the time, we had a 29-year-old female.
I'm sorry, I have a dark screen.
I don't know. It's your problem. I have a good screen.
Yes, so I don't know why. For me, it's a dark screen. It's totally black. So I don't know.
Perhaps you can share the screen again, Beatrice.
Okay.
definitely, I think we should move to Zoom, which is possibly much more flexible. I continue to have the same black screen.
Okay.
Anyway, so we will continue.
Well, I don't know.
I'm allowed to have this black screen. We should continue, not to lose time, please.
Okay. So is this okay for everyone else?
Yes. But then
Yes.
I think there's somebody else should take the moderation if René cannot see.
Yes.
So, Bismuth, you can see.
Please.
Okay. So back in 2004, this patient had a laparoscopic cholecystectomy for symptomatic gallstones. So at the time, her main symptom was epigastric pain. The procedure went by in a routine fashion. There were no immediate complications. However, 1 year later, she began complaining of right upper quadrant pain with elevated gamma GT, and an ERCP was performed with stone removal. In the next couple of years, she was never fully asymptomatic. She always had some sort of abdominal pain in her right upper quadrant, sometimes with worse episodes with nausea and vomiting associated with fatty foods ingestion. And several ERCPs were performed with sometimes with stone removal, other times the exam was normal without any findings. So in September 2014, she went to the emergency department with an episode of fever and chills with some abdominal pain, mostly in her right upper quadrant and also epigastric. Her blood work was normal, except for a slight elevation of GGT. A CT scan was performed, which didn't show any changes besides an enlarged lymph node in the liver hilum. And it was decided to do an ERCP, which showed no intrahepatic bile duct dilation, but multiple stones in the main bile duct, which were again extracted. After the ERCP, her liver function tests were normal, and a cholangio MRI was performed, which was also normal according to the reports that we had. In the next couple of years, she sometimes had pain, but could manage it with a strict diet. But in October 2021, she began complaining this time of a strong abdominal pain, either spontaneous or associated with fatty food ingestion. Her blood work showed a slightly elevated AST and ALT, less than 2 times the reference value, with a slight elevation as well of GGT and AF. Her amylase levels were always normal. So her upper GI endoscopy is normal as well. Colonoscopy also normal, no changes. She did a full panel of gynecological exams, which also didn't show any changes, and even a PET scan, which was also normal. So this June, it was decided to perform an ERCP, which we have the images here, as you can see. So there was some sludge in the main bile duct, but no stones. And there was also a stenosis of the sphincterotomy. So a plastic stent was placed at that time to try and calibrate the sphincterotomy. However, the patients began complaining of strong pain almost immediately after the procedure. And the procedure was repeated to remove the plastic stent with improvement of the patient's symptoms. So in July, we did a repeat cholangio MRI, which doesn't show any significant pathological changes, just some anatomical variants, mostly an insertion of the posterior duct in the common bile duct, and also a slight loop in the cephalic portion of the Wirsung duct. There is also a little bit of fluid in the upper abdomen, peritoneal fluid, but slightly less than in previous exams. So there is no intrahepatic bile duct dilation. There is no main bile duct dilation. And you can see here just some, a little bit slower. And here, the bile ducts.
Can you show the head of the pancreas a little better, Beatriz?
Okay, I will try.
I have to say, what impressed me was the intensity of the pain and the lack of quality that this patient has. She was referred to us by the gastroenterologist some months ago, and this is very, very impressive. She called me today, saying that she was going to the emergencies again with another episode of right upper quadrant pain.
Hugo, if I moderate, does anybody have an idea? I have an idea. Alessandra has an idea.
May I say something? Pietro?
Alessandra?
Thank you. Did this patient ever had an ultrasound looking for LPAC syndrome?
No.
Can you explain, Alessandra?
So I was thinking about LPAC because of the recurrent bile stone problem. These are patients that makes lots of intrahepatic stones that can migrate, and the only treatment is the ursodeoxycholic acid.
Which she is doing, anyway.
She is, okay.
She's doing, we put her on ursodeoxycholic acid without any kind of improvements.
Yeah.
And we have no sign of stones.
Ultrasound. I think the ultrasound you should do, because at least the diagnosis is very typical, and you can see the stomach tails from concretion on the bile ducts. And when you look for it in recurrent pancreatitis or in recurrent bile duct stones, you find it more and more. John?
No, I would agree. I mean, the pathology is reformation of stones, and I think this patient may also have developed, even after the sphincterotomy, a papillary stenosis picture, which you saw on the ERCP, had a lot of pain, and when you put the stent in, I wonder if we're dealing really with a picture of the pain being caused by recurrent papillary stenosis from passage of stones. In which case, a sphincterotomy, a formal sphincterotomy may be necessary.
She did, I think, 7 ERCPs with several sphincterotomies. The last one enlarged the sphincterotomy, and she still has pain.
Still has pain. Okay.
But in this case, I think you should do the biliary anastomosis to mount a loop. And
I've thought about that also, yes.
But I would continue the ursodeoxycholic acid at the highest dose.
Why the deoxycholic acid?
Beg pardon?
Why the deoxycholic acid?
Because I think that the primum movens in this lady was an LPAC. I would ask further questions. Did she have jaundice in pregnancy?
Sorry?
That's a family's history. Did she have jaundice in pregnancy?
We don't know. I'm not sure if we...
That's one of the questions that should be asked, because generally these patients have jaundice in pregnancy. And when you look for the mutation, about half the cases have the mutation, but another half have deletions in the MDM4 gene, whatever it's called. And then you don't find, it's very difficult to look for deletions rather than for mutations. But I think we have a cluster of that in our region in Switzerland. So we are very well tuned to find that. But typically the patient who presents with recurrent stones after cholecystectomy, and then it's when you question them, and they don't have stones in the gallbladder. And in fact, the very elegant way to find them out is a young patient, male, with a passage of stones. And if you treat them, you don't even need to do the cholecystectomy. The symptoms are controlled. And the diagnosis is a simple ultrasound.
Pietro, to support what you said, generally speaking, when you have stone in the biliary tree after cholecystectomy, there is two ways of formation of stone. Or they are forgotten stone, or they are new stone. And if they are new stone, it is with a stenosis. So the question is, if there are no forgotten stone, you have to look for the stenosis. So you suggest a stenosis at the level of the papilla, but say no. At that time, there are new form stones without stenosis. And your suggestion, for me, is the more logical.
It's Alessandra's suggestion, but we are lucky because we have a cluster of these patients in Italian Switzerland.
So just one curiosity, Pietro, what are you expecting to find in the ultrasounds?
I'm not very good, but Alessandra will find you a case and show it to you in a second if you want. And she will show you. Alessandra,
a well-trained radiologist can find comets inside the parenchyma, like a specific sign. I will try to find an image.
If you find an image while I present our case, can I present our case?
Yes, do it.
I'll try.
So about this, you propose bilioenteric anastomosis to this lady?
If you have tried ursodeoxycholic acid at the highest dose, which is 15 milligrams per kilo per day,
yes,
then I think yes. But by now she might have the stenosis after all the sphincterotomies she's had. I thought I could present, and I can't.
Hugo, did you perform analysis of the stone? It is cholesterol stone or pigment stone?
We don't have an analysis of the stone.
I do it.
I can't share my screen. Last. PowerPoint, maybe this. Let's try consenti. I may try to come in. I will leave the screen and try to come in with Google Chrome. I think this program is the best.
Try with Google Chrome. I have done the same, and now the image appears. Okay, Hugo, just a question. You did looking for the mutation of MDR3 in this young lady?
I don't recall doing any kind of genetic test for this lady yet.
Because she may have, I would say, a profile of molecular profile of mutation of MDR3, in addition to what is the proposal of Pietro.
Yes.
Which predispose, of course, to litogenesis.
Yes, I think we will check. How many times do you think ursodeoxycholic acid should be done before we can propose eventually bilioenteric anastomosis? Because he's doing perhaps at 1.5 months or something like that.
Alessandra, you may.
Was it the maximum of a dose?
She's doing, she has 60 kilos. She's doing, I think, 750 milligrams a day.
So probably enough. I don't know, maybe she also has a stenosis after all the RCPs that she had.
Okay. So is there any, in waiting for the connection of Pietro, is there any other case, Hugo, in a way not to lose time?
Yes, so we have a case from Pietro, we have a case from Tomoaki, and Manuel Jack, which has a case also to share.
Okay, so you say a case from Tomaki?
Yes.
Okay. I don't know if he's connected. Tomoaki, Dr. Kato, could you present your case? Apparently, yes. Some difficulties to share the screen. Dr. Kato.
Oh, sorry, I should just click the present, right? Entire
Yes.
screen and allow.
Let me just say that Manuel Jacklich just called me and he cannot present because he went to the OR.
Oh gosh, I don't know what's going on. This I can see infinite number of this screen.
Absolutely, yes. The same we have in our screen. Yes, now it's okay. It seems to be okay.
Do you see it?
Yes.
Yes.
Do you see it? Okay, staff meeting. Okay.
Sure.
So this is really not the presentation for surgery. It is a post-operative complication presentation. But just to show you the surgery was, this is a centrally located advanced HCC, really infiltrating major hepatic vasculature and a right hepatic vein orifice. Patient received Y90 and immunotherapy with a good response, but still has an issue. So we did a ex vivo hepatectomy. It's a very short video. I'll just show you how we did it. It's not so easy to see how we did it, but this is a temporary portal cable shunt placed during the hepatectomy, and
I'm sorry, just one curiosity. What's the diameter of that?
Dacron? I think this is 12. It was maybe a little
12.
too big. And then arteries cut, and then liver is excised to ex vivo. Then we just resect, replace the vena cava, and so restore the portal flow, the portal cava flow, and then we just excising the liver at the back table. As you see, the left-hand side is the autograft. I'm sorry, right-hand side is the autograft. Left-hand side is the tumor. So you see that the right hepatic vein is kind of cut in pieces, and the right anterior branch was infiltrated. So we have to cut the right posterior branch and create the right posterior graft. And in order to reconstruct the vena cava right hepatic vein, we create this patch and then just anastomose the liver back in. So it's like a right posterior liver liver donor transplant, but it was done as an autograft. So the surgery went fine, and then he was doing fine. But by the way, the biliary anastomosis, I chose to do duct-to-duct anastomosis, which in retrospect was a mistake. But we did that because I thought the bile duct can still reach. Because bile duct area there's no tumor infiltration, and then mostly the outflow issue. So, but anyway, the exterior resection was done in April, and then about 20 days later, he developed the cut surface correction, and then drain has a bile tinged. So we did a ERCP, but that time there's no evidence of bile leak, and the plastic stent was placed, but there's still persistent collection. We went back to the OR for X-lab washout because he was becoming septic. And we saw the abscess right at the vascular graft area. And then we put the big Devo drain in there and start washing, and he got better. But months later, he was still in the hospital due to sort of ongoing in and out of sepsis. And then we still see some extravasation from the bile duct. So we did an ERCP again. And at that time, ERCP showed very big anastomosis. The ERCP that time, didn't show that extravasation, but very narrowed area. So they put the plastic stent. But after that, he developed a very bad bile leak from the drain. So drain started to leak a lot of bile. So we don't know what point bile duct was injured, but at least after ERCP, drain output in a bile got much more. And then we put the IR, interventional radiology, put the PTC, and then passed the leakage area across. And then ERCP stent was removed. So that's the area of the cut surface leak, how it looked. It wasn't big, but he really became septic because it was close to the vascular graft. And then this is the picture of the IR cholangiogram. So as you see here, the huge leak. That's the duct-to-duct anastomosis, huge leak, but there's also small bile duct is going very near the leakage point. So we thought that maybe this is the time to go back to OR for the reconstruction. But there was no way when we opened it was just so terribly adhesed and scarred, and there was no way we can approach to the bile duct. So we avoided the surgery, and then we've been thinking what to do from here. So the question to the team here is that what would you do to this situation? And then what are the options? I'm going to present you what we did for this, but we don't still know exactly if that solved the problem yet.
So thank you, Tomoaki. It's a very, very interesting case, and you should be congratulated to have been successful, at least for the liver. Of course, there is a biliary complication, and now it's open for the discussion from the audience. So your question regard, I would say, the treatment of this biliary fistula.
Exactly.
Which my hypothesis is that it could be the stump of the anterior sector that has been removed, and possibly it's an open stump of this bile duct from the anterior sector. What do you think? So you have an hypothesis about the...
Yeah, just the anterior section of the liver is removed, and so the only right posterior segment is placed, and that was connected to the bile duct. So there was really no anterior sector bile duct. But a question is that it seems that the bile duct was okay for almost 2 months' time, and then suddenly opened up. It could be, what has caused the question essentially is that the ERCP rupturing this, or is this more or less the bile duct was already damaged enough and it was just impending problem. But that's one of the question to the team, how it happened, but also second question is how to deal with this leak. Thank you.
So comments from the audience?
Yeah. First question, at the time of surgery, After you said you did an immediate biliary reconstruction, as far as I understood, so without T-tube or anything in, right?
Right, no T-tube.
Okay. Do you do, as a routine, usually before closing, a blue dye test or anything to see whether you have a major leak on the cutting edge?
No, no.
So you don't. Okay. Now we second, because it may have existed at that time. The second question. Now you have a leak. You didn't comment how much is bringing per day. How much bile you have?
Yeah. So this time of this picture, it was about 500 cc coming into the external drain, and then less than 100 cc coming out from the PTC.
Okay, so in total, it's about 600 per day.
600 to a liter, actually. Sometimes it goes up.
To a liter. And how far are we from the operation?
So this picture was about 4 months from the surgery.
4 months, okay. So this is a major leak, basically, that you have, which is not closing.
Right, so the major leak, but it's probably happened later time frame because of the abscess, combination of abscess, and probably very friable underperfused bile duct.
And the liver is cholestatic or not?
Liver, it was not cholestatic at that time. It was bilirubin was normal.
Okay, because of the biliary fistula. Pietro?
Right.
I don't know what happened. Pietro, you want to make a comment?
Yes. If I understand all right, there is a PTBD that's stenting the whole thing and going into the duodenum, all right?
Right.
Yeah. And did you try to close this drain, and what happens when you close it?
The capillary drain, you mean?
Yeah, the transhepatic drain going into the duodenum.
Right, right.
Because what I would do is to make further holes into that drain and then bridge the leak. And sooner or later, the leak will stop.
Yeah. Yeah, so that's sort of our usual strategy because there's an external catheter catching the drain, the leak, and also there's an internal external catheter that can decompress from inside. However, though, even at the time of open drainage, the biliary drain only drain 100, and then most of the bile that goes into the leakage, and then about 500 cc of bile is coming from the leak. So it looks like the hole is too huge that is going to be closed in the usual strategy. Probably because of the biliary duct wall necrosis.
No.
And it's a kind of big permanent hole.
And I gather that the artery is fine, isn't it?
Artery is fine. Artery has been fine.
Then what we would do in these cases is just to buy time until you can reoperate.
I will remove the drain.
Other comments?
Yeah.
About operation?
Yeah, can I make a comment?
We have them drink the bile or re-administer it with a nasogastric tube.
Okay. Thank you, Pietro. Dimitri?
I just want to bring an idea at something that actually I think we did when I was at Paul Bruce with Professor Bismuth once, and then I did exactly the same thing. I had a similar situation with a case also at HCC that after a major hepatectomy had chronic drainage for several months like that. So what we did is we exchanged the pigtail to a red rubber catheter into the leak and waited probably good 2 months until it formed a really good tract. And then I went in and literally dissected that tract off the skin and came as close as I could possibly be to the leak area following the tract, and then reanastomosed that to a loop of bowel, to like a Roux-en-Y. And I think We did a case like this in Paul Bruce, and then I did this again here in New York, and it worked really, really nice. As long as the tract is very well formed, but you need a rubber latex catheter to form a good serious inflammation around it. So the tract is formed. I think Professor Bismuth probably remembers cases like this, because I definitely learned that from you.
Other comments, other proposals?
Close the train. Close the train.
Yeah, one thing that I was going to say also, I think I had a similar case, not with an ex vivo, but with left trachectorectomy that had a very big fluid leak, bile leak, and it was in fact a very large hole that I think it was totally impossible to close, even with stenting and drainage. And so we managed to get there after some, I think, 2 months. And we did exactly what Dimitri was saying. We put a loop of jejunum, Ru and Y, and it ended up solving the question. Although I think it may be very, very difficult to reach that spot. Sorry?
You did it easily because it's always...
No, it was extremely difficult.
Yeah, the tract forms very, very strong, and it's surprising how you can actually do this in anastomosis. Actually did it robotically, and it worked out really, really well. So.
Yeah. This case, though, still the cavity is wet, so I don't know the cavity if collapsed small enough to do that, but it will take a while. So I'm hoping, that might be the case. We saw that, we discussed with the interventional radiologist, and they came up with the idea to place a fenestrated covered stent, meaning that it's a covered stent, but it has a wall, holes in the stent, and then place the covered stent across this leak, and then seal the leak, but not to close this bile duct. So we don't still know if that's the solution to the problem, but so this is a very interesting stent they came up with to just close a close, and then those little bile ducts supposed to be draining into that stent, and then the leakage is less right now, but his bilirubin is going up right now, so I'm not so sure if that's the solution of the problem, but that's what we did so far. And then hope that this would at least temporize the problem, because issue of him was that he is still very much deconditioned and deteriorated. So if we don't do something to close that leak, we saw that he may just lose ground and then go into sepsis and die. But that's was the idea we have done. Has anybody done this type of covered metal stent, fenestrated covered metal stent idea for this bile duct leak sealing?
So may I give my suggestion?
Yes, Valerio.
We had a few patients treated for chronic biliary fistulas postoperative with internal drainage, so transgastric or transduodenal stenting, which worked really very good. So unfortunately, Tomaoki, I didn't see your presentation because the screen is black. I don't know. Apparently, it's only for me. So I didn't see the case. I heard all the story, but our endoscopists did all a series of patients with transgastric stenting. Really, so it transforms your fistula in internal fistula.
Sure.
Yeah.
Personally, I will converge with what has been said by Valerio and by also Pietro Maino on the fact. I think the reoperation should be the last resort in such type of, I would say, of problem. And really, a biliary fistula always finish to be closed. The problem is to have a very effective biliary drainage. And by this way, it could be by transhepatic, it will be by endoscopy. But the game, if I may use this word, is to try to reverse, I would say, the drainage from the fistula to the biliary drainage. And so we should optimize as much as possible this drainage in such a way that the maximum of bile come from the biliary drainage and not from the fistula. And from the time we reverse, I would say, the flow, at that time we gain, and with time we'll totally finish and finalize, I would say, the biliary fistula. But of course, sometimes it needs time, it needs tenacity, it needs also all the effort of endoscopist and surgeon. But I would try to do all my best not to reoperate the patient, because of course it could be if at 6 months we are in the same situation, but I would prefer to do biliary drainage much more than the reoperation.
And Tomoaki, if I may, who's moderating?
Sure.
Yeah. I know it's weird and you laughed at us, but it's amazing how giving back the bile, the patient conditions them, and it's impressive. So this is the thing I would do today.
Refeeding bile.
Yeah, is it feeding a small nasogastric feeding tube just for that?
As far as you were speaking about the jaundice, but basically this is what at the end you're looking for, because you're trying to close this bile fistula, and probably it will develop as a stricture. But it's just a long-term antibiotics, NG tube, and compensate as much as you can this bile that you are losing. But it's true that you have to avoid sepsis, but you have to wait. It takes time.
Right. Yeah. So that's sort of our hope. This stent probably has caused a segmental duct obstruction because it was too big, but at least decreased the leak. So I'm hoping that this may become chronic fistula, like you said, the fistral jejunostomy could be possible in the future. But right now we need to get out of this situation. And this jaundice just happened is a little concerning because his bilirubin was completely normal until this covered stent was placed. Now that it's going up, so it might be partial obstruction. So when they treated the one problem to the other, could be in a worse way. But I will see, and I can probably report back to you what happened to this case. By the way, the tumor hasn't recurred, margin was negative, and he's survived for this month without the recurrence. That's so far is okay for the oncological.
Just to comment, the first one is that I think it's much better to have a biliary fistula than the jaundice of the patient, because at that time it becomes septic and he is life-threatening for him. And so could you remove, I would say, these prosthesis you have put to bridge the fistula in a way to solve the problem of jaundice? Because by this way, the liver doesn't suffer. Okay, we have the fistula, but much better the fistula than the death of the patient. So
that is true. That is true. Yeah. But
sure.
Go ahead.
Please.
No, go ahead. Because of the internal catheter is still inside, of this stent, so we just exchange it to see maybe the internal catheter inside the prosthesis was causing obstruction to just rule out the problem. But yes, you are right. If he continues to have a jaundice, this is a worse problem than the leak.
Okay. Any additional comment or advice to Tomoaki? Okay, so you will keep us informed, Tomoaki, about the outcome of your patient and what finally you will have to decide. Okay, so Tomoaki is possibly disconnected temporarily. So we go now to the next case.
I think it's
of chairman. We change of chairman or not?
Yes, to chair the chairman. Who wants Gina? Gina must be the chairman now. Gina.
So this is the last case that we have.
Okay, so who's presenting? Is it Manuel?
I would like to present, but
Oh, Pietro.
I'm blasting. I can't share my screen. And I don't know what.
Did you go?
Manuel is not presenting, so it is just Pietro's case.
I have honestly an interesting case to present.
Pietro, did you go to Google?
I think I will send to the Compagnons on the mail a Zoom link, because I can't, and I really need you for this case.
But Pietro, did you try Google to open Google?
I'm in Google. I'm in Google, and I'm trying to present this flag, but it's probably because I refused to subscribe to Google Workspace, and they blocked me.
Pietro, can you email your presentation to say Hugo, and maybe Hugo can?
It's 40,000. It's
too big.
Way too big. I got films and. So I'm afraid for the other compagnons who are looking on the channel, it will be missed. But at least if I send you an email now with my Zoom, we can go on Zoom and discuss about it, because I really need your help.
We may do an ex-situ.
Exactly. we do an ex-situ.
Not ex-vivo, but ex-situ.
We transfer the meeting. I send you the link now.
But why do we always use Google Meet? I think it's so much easier.
It's a nuisance.
We should
send you.
I think let's do Zoom next time, because it's so much easier.
No, we Zoom. If you don't mind, we Zoom now, and I send you the link now on Hugo's mail. On the last mail. Just give me 2 seconds.
Okay. Well, usually it used to work, but whoever wants to change the settings will ask Hugo to tell us how to do it then.
I'm not. I think it is Danielle that is in charge of the media here. But yes.
Okay, but today we don't have any Zoom link, so I don't know how we can reach this.
We have to see in the mail, because Pietro is going to send us by mail a new Zoom link.
But did he send it already or not yet?
I think I'm just going to check.
No, I have not received.
I don't have it yet.
Okay.
Not yet.
Okay. In the meantime, may I just ask to Tomoaki for your case? I presume your patient is on long-term antibiotics, right?
Yes.
Yeah. One of the risks also he's facing is some sort of vascular pseudoaneurysm. And that's one of the risks that he's facing in your critical period.
Yeah.
So.
Yeah, so far the artery is okay. When we explore, we just be so careful not to really go anywhere near the artery. That was part of the reason we couldn't reach the bile duct at all. Okay. But so far that part is okay.
Okay, great. So Hugo, do we have the link or?
We just have the link right now. Pietro just sent actually, it just sent to me.
Okay.
So I will send to everybody.
Or can you send it through this Google link to the chat or email?
I think you prefer, I can send by message right now. It's here. If you just right now.
Okay. So we just copy it, right?
I think, let me see. I think it's just to click.
Okay.
If you just click it, I think it's going to work.
And then close this.
Yes, it's working.
Ah, nice.
So where is your, okay, nice.
Okay, I'm in Zoom now, yes.
You should close the other one.
Okay, we should close the other one, exactly. Bismuth,
I didn't get the link. Can you resend it to me, please?
Hugo,
Yeah,
how
it's
do
in the
you send them a
messages.
link?
It's in a message here. You can see in the message.
Hold on.
I have
For
not,
everybody?
Wait for a
no,
second.
I
no,
don't see
I
it.
have not received your message.
Henri?
Hugo.
Okay, so I will
Voilà.
send the link to everybody, okay?
Yes,
That's better.
thank you.
Okay, let's do that.
That's,
Yes, okay, it's in the messages here of the,
Oh, I see it.
the
Yeah.
meeting. Yes.
anyway, I'll send the link again.
I can send the link on WhatsApp if you want.
We see you. Good.
So
It's
I
good.
just sent the link by email to everybody.
Yes. Shall I send it through WhatsApp, Hugo, as well?
Yes, perhaps it's useful. I'm already